Welcome to Health Professional Radio. I'm your host, Neil Howard. Glad that you can join us for another segment. We're going to be speaking with Dr. Keyan Salari. He's joining us here from Mass General and Harvard Medical School to discuss a presentation at the AUA 2021 annual meeting concerning prostate cancer. Welcome to Health Professional Radio, Dr. Salari. Thank you for joining.
Thank you, Neil. Thanks for having me.
Now, I mentioned, of course, that you're joining us here from Massachusetts General and Harvard Medical School. Give us a bit of your professional background and talk about your roles.
Sure. Thank you. I am a urologic oncologist at the Massachusetts General Hospital Department of Urology and MGH Cancer Center. And I also serve as the co-director for the Prostate Cancer Genetics Clinic at MGH Cancer Center.
Now, there was a presentation that was given at the American Urological Association 2021 annual meeting concerning the impact of positive family history and active surveillance for prostate cancer. Describe this impact of positive family history and hereditary cancer-associated malignancies on outcomes of active surveillance for prostate cancer presentation, if you would.
Sure. So active surveillance, as you may know, is one of the preferred management strategies for men with low-risk prostate cancer, whereby instead of treating the cancer with active treatments like surgery or radiation, we closely monitor the disease with the thought that it's a very indolent form of prostate cancer that may not ever come to harm the patient if just left alone and just monitored. And by doing so, we can avoid some of the side effects and risks of treatment. Over the years, we've had a growing appreciation for the role of genetics in prostate cancer risk and outcomes. And now the NCCN recommends newly diagnosed prostate cancer patients with a strong family history of prostate cancer or related cancers to undergo germline genetic testing for various genes, including a number of DNA repair gene mutations. And so we have the hypothesis that men who are at a higher genetic risk for prostate cancer might be at a higher risk for progressing to needing treatment on active surveillance. And so that's what we were investigating in this study, looking to see whether the impact of a strong family history that suggests an underlying genetic syndrome, what impact does that have on active surveillance outcomes?
So if I'm understanding correctly, a strong family history may suggest more active disease as opposed to no family history, and active surveillance may be going on for the patient's entire life without becoming aggressive. Is that what you're supposing?
Yeah, that's exactly the idea. There had been prior studies looking at the prognostic impact of a family history on the success or failure of active surveillance for a given patient, and the results have been fairly mixed, and most studies showed that it did not make a difference. And so, in terms of the eligibility criteria that we typically use for selecting patients for active surveillance, family history was not viewed as kind of a hard factor to, think about in terms of selecting a suitable patient for active surveillance. One of the differences in our study is that now that we've learned more about the genetic associations between prostate cancer and other cancers, what we did for our study is look at not just a family history of prostate cancer, but also other related cancers like breast, ovarian, and pancreatic cancer. Some of the strongest genetic associations are with genes like the BRCA1 and BRCA2 genes, and we know that men who have inherited a pathogenic germline mutation in one of those genes, as well as other related DNA repair genes, have an increased risk of not just prostate cancer, but also male breast cancer, pancreatic cancer, and then their female relatives with the same mutation, breast and ovarian cancer. And so for our study, we looked at our patients who have been on active surveillance and looked at their kind of expanded family history, not just of prostate cancer, but of all those cancers that I just mentioned, to see whether their pedigree, their family history looked suggestive of one of these hereditary cancer syndromes.
You mentioned healing genes. Are these genes present only when cancer is present as well?
Well, the DNA repair genes are a set of genes that their job is to fix DNA when there's an error detected in it, when there's a broken segment or a mismatch of the DNA, et cetera. And they're present in all the cells of our body. But when you have a mutation in one of those genes, it can increase the risk that the cells that harbor that mutation can form a cancer. Why patients with, BRCA1 or BRCA2 genes, which are both types of DNA repair genes, preferentially form, prostate, breast, ovarian cancer, et cetera, we don't fully understand that, but that does seem to be a very strong kind of association. So when you look at families that have one of these genetic mutations running in their family, you see kind of a clustering of those related cancer types. So we used that information to our advantage, so to speak, in the study to infer whether there may be a genetic underpinning to the cancer cases that were running in these families, and then for those families, look to see whether, if men were on active surveillance, if they had any negative impact on the success of their active surveillance.
What were the final conclusions? Are we going to employ this hereditary test on a more wide scale? Do you think that is what's going to happen as a result?
Yeah, well, I think we had some interesting findings. So we among the patients that we've had on active surveillance at Mass General who had enough follow-up time and detailed family history available, we had about 1,000 patients that we were able to look at. And if you just looked at any family history of prostate cancer, about a third of our patients had family history of prostate cancer, in at least one relative. But if you look to see who had a really strong family history that suggested one of these hereditary cancer syndromes, which again included not just the history of prostate cancer in the family, but also breast, ovarian, or pancreatic cancer, there was about 10%. 10% of our cohort had how we defined as a strong family history, meaning at least more than one first-degree relative or first-degree relative equivalent that had one of those cancer types. And it's kind of interesting because if you looked at anyone who had a family history of prostate cancer, that was not a significant predictor of failing active surveillance and going on to needing treatment. Having a biopsy on surveillance that showed more aggressive disease, in other words. But if you looked at this metric we developed of a strong family history suggesting a hereditary cancer syndrome, it was significantly associated with having progression of prostate cancer, on a subsequent biopsy, and therefore ending up needing treatment. And so if you look at the hazard ratio, it's about a 42% increase hazard coming off surveillance due to biopsy progression among men who had this strong family history suggestive of a hereditary cancer syndrome. We also looked to see whether there was any difference in the pathologic outcomes for men who ended up needing surgery, to see if the cancer had looked any more aggressive on surgical outcomes. We didn't find a significant association there, although that was underpowered since only a subset of the patients who ended up having biopsy progression underwent surgery. But it also at the same time may suggest that those patients didn't, quote unquote, lose the window of opportunity to be cured. So I think the takeaway from our study is that a strong family history that suggests a hereditary syndrome is significantly associated with an increased risk of biopsy progression and progression to treatment among men on active surveillance, but it doesn't outright exclude them from being able to undergo surveillance. It could still be an option for them. They just need to have an understanding that they're at higher risk of having progression of their disease and ultimately needing treatment. So I think that's the appropriate way to interpret and use this data to counsel patients in the future.
Well, Doctor, if you would give us a website where our listeners can learn more about Mass General and about this presentation as well.
You can learn more about Mass General from the Mass General website, www.massgeneral.org. And there should be information about this presentation on the AUA 2021 website as well.
Thank you very much, Dr. Salari. It's been a pleasure speaking with you, and I appreciate you giving us this information. Thank you so much.
Thank you very much for having me, Neil. My pleasure.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Keyan Salari. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download it, SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.